Good afternoon. Welcome to our webinar on mental health of people with migration and refugee background in a changing Europe, challenges and solutions. My name is Meryam Schouler-Ocak. I'm professor of intercultural psychiatry at Charité Universitätsmedizin Berlin in Germany, and I am the current chair of the EPA Committee on Ethics. It's a great pleasure for me to chair this webinar, which was organized by our Committee on Ethics. We could win really distinguished leading expert in this field. Let me say in the beginning a few words to our webinar. Migration is a global phenomenon which is not a new fact. It exists as long as human beings. Today, in many countries, there is a focus on people with migration and refugee background, and it is discussed controversially. At the same time, mental health problems are a major cause of global and societal stress and are a growing health problem in the public health concerns. Migrants and refugees are at risk of receiving poorer quality healthcare due in part to racist and discriminatory attitudes, behaviors, and policies in the health system. Furthermore, despite fleeing war and conflict, exposure to torture and traumatic events, and living with uncertainty, these people are at high risk of experiencing long-term poor physical and mental health outcomes in their host countries. Over the past years, the social political climate has been made marked by conservative anti-immigrant rhetoric, policies, and actions, leading to increased distress and fear and mistrust within people with migration and refugee background. Furthermore, the legislation stipulates that the member states of the European Union have a legal obligation to provide for the social and health needs of asylum seekers and refugees. But restrictive legislation can hinder needs-based access to mental health care and lead to health inequalities, which is one of the topics of our webinar. And I'm very, very happy to introduce you to our working now. Please, if you have comments or questions, insert them using the chat possibility. We will go on with our presentations first, and after both presentations, we will get back to your questions and comments. So I invite you to write your comments and questions using the chat possibility again. I'm very, very happy that more than 190 colleagues registered for our webinar, and I hope that many of them will join it now too. So we are going on with our experts. I'm really very honored and pleased to introduce our first speakers. It is Dr. Marianne Kastrup. Dr. Marianne Kastrup was born and trained in medicine and psychiatry in Denmark. She has always been interested in working with underprivileged populations, and she led the Center for Transcultural Psychiatry in Copenhagen University Hospital, Denmark, for several years, and was the medical director of the International Research and Rehabilitation Center for Torture Victims in Copenhagen, as well as the consultant and head of the Department of Psychiatry in Copenhagen University Hospital in Hvidovre. She is presently chairing the Anti-Torture Support Foundation. Marianne Kastrup is many, many years in the field of cultural, transcultural, or intercultural psychiatry. She chaired the section on transcultural psychiatry, the World Psychiatric Association, for many years, and was member of the board of the World Psychiatric Association and also EC member in this association. Furthermore, she is also a very big member of the European Psychiatric Association because she was Secretary General of the European Psychiatric Association for more than 10 years and chaired the Committee on Ethical Issues of the EPA for approximately 4 years. I'm now very, very happy to hand over to Marianne Kastrup and to present her talk on mental health of people with migration and refugee background, data and facts. Marianne, the floor is yours.
As I already mentioned, that migrants is a much vaster population than the population of refugees, and that for the moment, more than 4% of the entire population of the world live outside the country of their birth. Next. If we look at the UNHCR, we are talking about here, these are more within the mandate of refugees and displaced persons. And here, it is 1 in every 69 persons in the world that are forcibly displaced, and that it's good to remember that 3/4 of them live in low and middle income countries. Sometimes those of us living in the Western world think that all the refugees have come to us, but this is not at all the case. Next. Let me just share with you 3 recent conflicts, and I'm not going to talk about the present problems in Syria, but just to let you know that within the last couple of years, we have seen a conflict in Sudan where more than 6 million people were displaced within the country and more than 1 million were fleeing to neighboring countries. And in Palestine, the United Nations Relief and Work Agency found that 1.6 million are displaced because of the conflict in the Gaza Strip. And in Myanmar, there was a military takeover in 2021, and we see more than 1 million people displaced in 2023. So we are really dealing with a lot of problems. Next. Coming to Europe, and this is purely because this is an EPA seminar, we saw a few years ago that there were 20 million of concern of the UNHCR living in Europe. But after that, we have seen the conflict in Ukraine, where the Russian invasion had as a consequence that more than 14 million people had to flee their home, and that about 6 million had to go to a neighboring country. Next. So the present situation from a social psychiatric point of view, and this is what we're going to discuss today, is how are we as health professionals managing to help the increasing number of refugees that require mental health services. Next. You could say, should we have health checks? Should we say that persons who enter our countries have to be screened for mental health problems? Well, WHO has considered this, and they do not recommend a compulsory screening. They say there's no clear benefit, and there might be a drawback. It might trigger anxiety in those who are really going to be screened. It might prevent some persons from seeking help. So instead of doing it mandatory, it's much better to do checks on a voluntary basis and allow easy access to healthcare and provide healthcare which is carried out with respect for the situation and dignity for the population. Next. But on the other hand, having said that, it's important that we identify the problems as soon as possible. It's also important to bear in mind that it's not only PTSD, it might be a complexity of mental health and somatic problems, and that we have to take into account all psychosocial factors in a cultural sensitive approach to this. Next. Let's look a little on the on the long-term outcome. Next. Bojic and co-workers, they emphasized already in 2015 that we have to be aware of that there is a significant and lasting impact of war experience. We are all very familiar increasingly that a lot of post-migration factors are very important, but nevertheless, exposure to war trauma has an independent effect on the current mental health situation. Next. They carried out a very extensive survey reviewing 29 studies, and they came out with the study that there's a very significant between study heterogeneity in when you look at the prevalence rate of mental health problems. And this can be due to a lot of different methodological problems. I have no time to go into that, but I think all in all, we have to be aware of that the prevalence estimates are in the range of 20% and higher. Next. It's also important that we are aware of what are some of the risk factors. We know that age and gender have certain problems in the sense that children, adolescents, and also the elderly population have an increased risk. Many women who are heading households may be in risk. We know that those who already before had mental health or other health problems, that they have a higher risk. Those who undergo a very complicated asylum procedure have a higher risk. If you are short or not having at all any family support or support of significant other, you may have a risk. And of course, if you are living in extreme poverty or that you lack documentation, you also have an increased risk. Next. So I will now turn to some of the questions that were raised about EPA and EU. Let's first look at EPA next. EPA has over the years carried out several guidance papers and policy papers. The first was in 2014, and Professor Bhugra and Professor Schouler-Ocak and myself were involved in this paper relating to the mental health care on migrants. Later in 2017, we saw a guidance paper on e-mental health interventions in PTSD treatment. And this year, we have seen a policy paper on the clinician treatment choices for PTSD. But let's go and have a look at the guidance paper. Next. The guidance paper focuses on different aspects. First of all, of course, the clinical aspect. What is it that it is important that clinicians do? Well, we have to be aware of, as I already said in the beginning about data and facts, we need available, clear information. But we also, of course, need sufficient available resources. We need competence training, and I will come back to that also when it comes to other stakeholders. But training in competency and cultural awareness should be an embedded part of the curriculum of mental health professionals. We should also discuss, in the light of the resources and the current problems, whether to choose specialist services or whether you can handle the problem with generalist services. This is an important issue when you look at how much resources are available. And finally, it's important that all health professionals are receiving cultural training. Next. Now look then at the service providers. Again, we are talking about cultural competence and diversity training as part of introduction, but it's also important that services that are available should be culturally, geographically, and emotionally acceptable and accessible. There's a lot of discussion whether you should allow all to enter mainstream services or whether you should provide separate services focusing on their particular problems. And this is very often a decision that has to be taken according to local needs and resources. We need regular monitoring. We need that the local needs being determined regularly, and also that we are auditing regularly and monitoring the services that we do and seeing what is really the impact, what are the shortcomings, and are there other things that we should rather focus on. Further, and finally, we have to look at a possibility maybe to use culture brokers and a cultural mediation. And next, please, on policymakers. Again, we are discussing education and competence training, But it's also, of course, important that policymakers provide resources that are meeting the needs of this population, that you have clear policies that take into account the complexity of the problems, and that you allocate appropriate resources for the training, and also that you collect accurate data and information. So much about EPA. Next. Let us have a little look, and this is my final part, on the EU funds. I have here taken some inspirations from European mental health that have questioned why migrants' mental health need to be properly addressed, and what are the key considerations in the light of the current EU budget. Next. Well, on the Committee of Economic, Social, Cultural Rights, there is the issue in comment number 14 that says that governments should ensure health facilities and services available, in particular for those vulnerable and marginalized sections, both in law and in fact. And this here is important. It also applies to undocumented migrants who may fear repercussions when they seek adequate mental health care. Next. At the level of the reception condition directives, again, it's important that we have standard of living and access for asylum seekers, including access to mental health. And it is stated here that the reception of persons with special needs should be a primary concern for national authorities. And then at the end, which is maybe a little as an excuse, at least emergency care and essential treatment of illnesses and serious mental disorders. So to speak, you can say they step a little back. But let's look at the next. Some considerations are useful, and I will end up by stating 4 considerations. First of all, it's important to strive for complementarity between EU funding and the national funding. It's always this issue, those of you who live in EU country know that there's always a balance between what can be carried out nationally, what can be carried out within EU. And next. It's also important, of course, that when you carry out mental health projects for migrants, that they have to fit within the national mental health strategy. But on the other hand, you have to build the capacity both locally in the municipal area, in the regional area, and in the national area, so that there is a capacity building to be able to fulfill the requirements if you want to provide good mental health services for migrants. Next. The third aspect is that we need EU fund to build this capacity. As mentioned also in EPA, we have to provide training for all frontline workers. We have to address barriers. We have to look at geographical, cultural, linguistic barriers and see how can we overcome them. And we have also to look at services also on a community based. And finally, and I think this is extremely important, we have to involve the civic society. It is not enough that on a political national level or EU level, if civic society and the organizations there are not somehow integrating migrants in what are they doing, I think that is very important. And my last slide. And then finally, we have to scale up mental health. This is an integrated part of the funding, and that we should oblige member states in the EU to look at how do they, in fact, carry out this. When it comes to practice, we have to follow them and monitor them, and what is the impact of these target groups. I think this is an extremely important topic for us all, somehow to look at how the politicians are carrying out this. And next. Thank you very much. This was my contribution. Thank you.
Thank you very much, Marianne, for this really great talk. You mentioned data and facts, but also EPA policies, which are still existing, and possibilities for funding from the EU, and other very important issues. I will ask the audience to write your questions and comments regarding Marianne's presentations. And would like to go on with the next speaker. And by the end of the presentation of Professor Dinesh Bhugra, we will open the discussion part. So I'm now very happy and also honored to introduce our next distinguished speaker. I think many of you know Professor Dinesh Bhugra. He is one of the leading experts in this field. Professor Dinesh Bhugra has published widely in the field of cultural psychiatry, sexual dysfunction, and service development. He has authored and co-authored more than 500 scientific papers, chapters, editorials, and 40 books. Several of his books have won awards and gone into multiple editions, and 3 of his books have been translated into Mandarin and Japanese language, great issue. His Oxford textbook for public mental health won Book of the Year award last year, and in the same year, Practical Cultural Psychiatry was highly recommended. Furthermore, Professor Bhugra is the editor of the International Journal of Social Psychiatry and International Review of Psychiatry. He was elected Dean of the Royal College and then its president. He was appointed chair of the Mental Health Foundation, and he is a patron of the Care It charity and the South Asian Film Festival, and serves on the boards of SANE and the Psychiatric Research Trust charities. He is also a distinguished friend of the Migration Museum, which is also great. He chaired the Dog Health Charity, jointly funded by the BMA and the Royal Medical Benevolent Fund, and he is currently a non-executive director of a Sussex Partnership NHS Foundation Trust. Professor Bhugra was also the former president of the World Psychiatric Association, and of course he is one of the biggest expert in this field. Therefore, we are happy now to listen to your talk, Dinesh, on refugee mental health. So the floor is yours.
Thank you so much, Meryam. It's really great to be with you all. Marianne has made my job very easy because she's done most of what I was going to say. But it just to highlight that before I start, we had some questions that people wanted me to look at, and I'm going to sort of run through those themes. The 3 questions were, the first one was concrete solutions for integration, and the second one is what should we be doing for women's mental health, particularly among refugees, and lastly, how do we support people who are part of the sort of search and rescue processes. Now, one of the things that I've become very upset about quite recently, that the term refugee has become a term of abuse. People just, don't think that many individuals would rather not leave home, but the circumstances are such that for their own health, mental health, and for their family and friends, they have to. So one of the options, maybe if we have time today or another time, is that what do we replace the term refugee with? It has 253 synonyms, but as we have often stopped using the term schizophrenic, we use the term person with schizophrenia. We don't use the term suicidal, with a person who has suicidal ideation. Maybe we need to reframe it and say somebody who's seeking refuge, in the same way somebody who's seeking asylum. So we know Marianne has already talked about the definition of migrant, whether it's within the country or outside, whether it's voluntary or involuntary. Refugee is an internationally agreed definition, which is about well-founded fear of persecution for reasons of race, religion, nationality, membership of an organization, social group, political opinion, sexual orientation, etc. And then we have displaced people who could be within the same country or elsewhere. And again, one of the things that I've become very interested in the last couple of years is the geopolitical determinants of mental health. And these geopolitical determinants look at things like the impact of conflicts, which Marianne has already mentioned. They look at the impact of disasters, whether they're human or natural disasters, impact of drought, impact of earthquakes, flooding, etc. But we don't think about these things because that displacement somehow doesn't count. The politicians play on this role that everybody is coming to the West for an easy life. It isn't an easy life. And as Marianne has already mentioned, that more than 2/3 of refugees and asylum seekers are in low-income countries like Pakistan, Turkey, Myanmar, Bangladesh, etc. So I have no idea what that is. I think for some reason it's closed captioning has come on. Okay, let's leave that. And asylum seekers also a legal definition, and people forget that countries have signed up and they have legal obligations to provide asylum to people who are seeking protection. And as I said, that the geopolitical determinants play a major role. And we know that, again, Marianne has already presented the data, so I'm not going to go into that. But by the end of 2022, 108 million people were forced to flee. And that number this year has gone up to 114 million, which is equivalent to the combined populations of France and South Africa. And we know that the refugees have some specific needs. They'll be experiencing distress, they'll be experiencing anxiety, sadness, hopelessness, difficulties in sleep, having fatigue, irritability, and then anger, aches, and pains. And I'll come back to those because those are somatic symptoms which are very important to understand from a clinical perspective. So how do we create that integration? It is by understanding refugee experiences, understanding the other, what they've been through. As the data shows that between 5 and 10% of refugees to the USA have experienced some form of torture, beatings. They've lost home, they've lost contact with families, they've lost livelihood, they've have relocation stress. And again, Marianne has presented the data, and I'm not going to go through that. But what's really fascinating is that somehow more than half of the refugees originate from 3 countries, Syria, Afghanistan, and Ukraine. And they, as I said, most of them are in low-income countries, Iran, Turkey, Colombia, Pakistan, and Germany was kind enough to accept over 1 million a few years ago. And perhaps Meryam can tell us a bit more about their settlement and what's happened after that. And there are obviously, as Marianne has already mentioned, that there are governmental and policymaker responses. And then there are professional responses, which is where clinicians come into play. And what we need to be thinking about is focusing on both physical and mental health needs. And part of the tragedy of medicine in the West is that we see physical health and mental health very differently. They're not. Physical health, mind affects body, affects mind, and we need to bear that in mind when we're dealing with people from other cultures, because their cultural expectations and cultural values may well be very different. They may not see that distinction between physical health and mental health. So even when they're feeling stressed, they may present with physical symptoms, and we need to be overly careful about that. How do we train people about resilience? How do we take into account those cultural factors? And again, I'm not going to go through the figures in asylum, but just to highlight that there are three major responses to forced migration. Mario Eisenbrook, a few years ago, did work with refugees from Vietnam and Laos and introduced this concept of cultural bereavement. And others have introduced the concepts of culture shock and culture conflict that we need to bear in mind. In addition to that, what we need to remember is that everybody has cultural capital, which is about being familiar with your own legitimate culture and bearing in mind that we are not born with a culture, but into a culture, and therefore we carry those bits of cultural capital with us wherever we go. And these are different from economic, educational, and social capital. So although there may be an element of some overlap. So cultural capital has three sources. There's objective, embodied, and institutionalized. The concept in this form came from educationalists. Bordeaux from France in the 70s and 80s, 1970s and 1980s, that is, described the idea of cultural capital, and subsequently other aspects have been added, which are technical, which means what are the marketable skills that we take with us, emotional, which is incredibly important from a clinical perspective, because that's how we understand. And then there are national facets. Now, quite often we use these national facets as stereotypes and stigmatizing, but we need to be careful about that. And then there are subcultural factors as part of that. So when cultures collide, first and foremost, we need to know about the strength and weaknesses of our own culture. Does our own culture predict behavior? Why people do what they do? And quite often, there's the question of looking for commonality. And we need to bear in mind that what are the new countries' responses? What are their values? What are their attitudes, which will influence not only behavior of the majority community, but also that of the minority community? And how, when minority community who are going through that bereavement, shock, and conflict and trying to deal with it, what response the majority community gives and what problems that creates. And in response to migration, almost everybody would go through a process of cultural expansion, which we take on cultural values to fill in the shrunk space which we may have lost due to cultural contraction, that we may give up some behaviors, some values, our language, our clothes, our way of speaking, our accent, our cultural values, and take other things. So in managing people, be they women, be they sort of concrete solutions for integration, we need to look at health beliefs, how people see health. And again, that goes back to combination of physical and mental health and what they see as locus of control. If they're suffering from something, do they see there's something outside them or something inside them? What are their beliefs in supernatural? People may feel that they're experiencing these horrible symptoms because somebody's cast an evil eye. Everything was going fine, but somebody said something and things have gone wrong. And these beliefs then dictate where we seek help from, where we seek treatment, how we formulate what we are going through, that experience. And part of the challenge for clinicians and patients is that how do we bring that congruence of models of illness together? So we can have supernatural beliefs, we can have natural beliefs, we have medical or biological, psychological beliefs, social, or a combination thereof. And these were identified by Wei-Xing Chen in about 20 years ago. And he argues that there is a trail if moving upwards. So very basic, very traditional society may have very supernatural beliefs. And his argument is that it could be seen as an evolutionary process as cultures change, evolve, people change, evolve, their beliefs may well shift. So the task for the therapist is that you must suspend preconceptions that you have about the group, migrant, refugee, asylum seeker, suspend preconceptions about their culture, whatever that is, and bear in mind that not everybody from the same culture is going to be like everybody else in that culture. People are individuals, people are different, and they may have different conceptualization of their symptoms. And part of your responsibility is being aware of that power and the privilege that you may have. And we may all carry these racial transferences, stereotypes, nationalistic or otherwise. So the challenges are, if you're a migrant and you have a mental illness, you're already in a double jeopardy. And it becomes triple jeopardy if you're a child, or if you're an older person, or if you're a woman. And so that may mean that you're facing double or triple stigma, which will influence prejudice and discrimination. And if services are not sensitive, you will reject the services. And therefore, forming those therapeutic alliances is very important. So as therapists, you need to know your likes, dislikes, your prejudices, your stereotypes. Be aware of your own identity. You must be neutral and open-minded, able to learn about other cultures. Be aware that there are differences not only across cultures, but also within the culture. And quite often, it would also mean that in many settings, people tend to idealize one culture, and there is this whole cultural transference and counter-transference that we need to be aware of. And that goes back to one of the questions about concrete solutions. But it's also worth bearing in mind that people from different cultures communicate non-verbally in very different ways. Keeping eye contact, avoiding it, facial expressions, gesture, speaking loudly, speaking very softly, speaking at a distance, and use and choice of words, vocabulary, that would depend upon education, it would depend upon a whole host of other factors. And we need to be careful that some cultures openly express anger. So that should not be seen as an attack on you, while others avoid it. You may feel threatened by expressed anger or confused about lack of reaction because the person is from another culture. And they may feel, you may feel unable to deal with the emotion. They may feel unable to deal with that emotion as well. And for many cultures, religion and spiritual values are very, very important. Let's not ignore them. It explains both natural and supernatural. It's integral part of many people's lives. It may explain explanatory models, attitudes to illness, help seeking, etc. And people may prefer to go to folk healers, faith healers, than medical professionals. So in order to be culturally competent, and this is, if you take nothing else away from this talk, just one thing, that every person that you deal with has a culture. It's not that migrants have cultures and we don't, or that refugees have cultures and we don't. So, cultural sensitivity, cultural knowledge, cultural empathy, and appropriate interactions, and being aware of strengths and weaknesses of your own culture. What are your strengths? What's are your religious values? And it's about um, being wise and humble. Look at interpersonal supports, because somebody who's migrated, whether willingly or unwillingly, their interpersonal supports are going to be very different. And you need to look at environmental conditions. Different ethnic minority groups, different cultures have different ideas about medication. Some like injections because they see that being more potent. Some like big pills because they think that those tablets will have more compounds and therefore will work more effectively. Others like very small pills because that means the compound is concentrated and more effective. Some cultures would prefer yellow pills, others would prefer green pills, some would like red. So we need to take those kind of cultural variations into account. So when a patient stops taking medication, we never question them. We never ask them that what are these reasons. And maybe those differences in diet, nutrition, body mass, and use of complementary and alternative medicine creates more side effects and people stop. So we need to take that into account. Psychological interventions we need to be very careful about because most Western psychotherapies are ego based. So if you come from a sociocentric culture, um, a group therapy, family work might be more relevant. Behavior therapy and cognitive behavior therapy may be more adaptable. Ethnically matching therapists and patients improves initial engagement, but not long term outcomes. And you need to be aware of indigenous therapies and their adaptations. We need to be aware of the geopolitical factors and the role politicians play in creating discriminatory circumstances. Policymakers can do a lot of good, but they can also do a lot of damage. And in answer to all the three questions, advocate, advocate, advocate. As clinicians, as members of the society, we have double roles. As professionals, we can speak for people who can't speak for themselves. As member of the society, we have the right to speak up and advocate for patients and their conditions, be they refugees, asylum seekers, or displaced people. And we need to be aware of variations in culture, variation in rates, and various potential explanations for that. So thank you very much for listening, and I'm happy to take questions, comments, thoughts, and discussion.
Thank you very much, Dinesh, for this really very comprehensive talk and bringing us many terms and open our eyes in regard challenges, but also possible solutions. There are many questions which I have in my mind, but maybe the audience has also questions. I just saw one question in the chat. It was by a colleague, Alice Bruni. She wrote, I would like to ask a question to our speakers. How do we contrast the constant disinvestments in public health, especially mental health in Europe, which generally trend sadly particularly affects negatively most vulnerable groups, of course, as refugees and migrants, women and children, youth first.
I think,
please.
Marianne, do you want to go first?
No, you can go ahead, no problem.
Because I think it is absolutely crucial that the the tragedy of health and mental health in particular is that we've become siloed, we've become separate. We need to link education, employment, housing, justice with health, including mental health. So public mental health becomes incredibly important. And one of the fascinating things in the recent years has been that there's a lot of research coming which is suggesting that simple things, and let me give you just one example, simple things like um, attachment patterns in childhood influence brain structures, which influence brain functioning. So it's teaching those parenting skills, supporting parents who may be struggling, making sure that they have good diet and access to services is part of the whole package. It's not and should not be seen in isolation. So, public mental health is about housing, getting rid of poverty, which we know is not going to happen in this kind of neoliberal capitalist world we live in. But it's good quality housing, access to green spaces, access to affordable food, healthy nutrition. And so we then go into this whole commercial determinants of mental health, which is, people are being fed ultra processed foods, which are full of chemicals, which produce obesity, which produce diabetes, which produce hypertension, which produce depression. So we need to get out of our comfort zones and start challenging and pushing the public mental health agenda.
Thank you very much. It's very interesting what you said now. Marianne, would you like to add something to this?
I agree, but I do think, as Dinesh was already saying, the word advocate, because I think a lot of it is also a political issue. Unfortunately, I think that we are here now in a European context, that in more and more countries, there's less focus on the public agenda, but the interest in the individual person, in carrying out things to have increased resources, to have less solidarity. So I think that a lot of it, to me, unfortunately, is a political thing, and that many political parties who were previously very much focusing on public issues are less so. So that's why I think advocate for some of these things that Dinesh was saying is very important.
I mean, I think just to, political determinants are incredibly important. And there's considerable research data which shows that since the introduction of neoliberal capitalism in the UK and the USA, rates of various psychiatric disorders have gone up. And suicidal ideation has gone up, rates of suicide. So we need to bear those broad factors in mind as well.
But just to underline that politics are going in right direction. So it's very difficult to reach them, to have lobby for migrants and refugees. Yesterday, I had a presentation and one colleague asked me, why can refugees or asylum-seeking people do not accept our culture and integrate them? So they mentioned that it is a one-way process and not an integrative process. So it was very difficult to give an answer to this, because it is very important that these people need time. It is not done by 1 day, 1 week, 1 month, 1 year, and so on. So it is a process. Many ways are going along this process. What is your opinion?
But I think
this integration or adaptation or assimilation wishes.
I think that there are challenges. I mean, you can't expect somebody to give up their own culture overnight and absorb the culture they moved to. So biculturalism has been shown to be a great strength. And you can think of a lot of people who migrated to America. How many generations did it take them to integrate? I was just thinking of Albert Einstein. So did he become American overnight? No, he did not. So it's a gradual process. And obviously, the second generation of migrants, and I use the term advisedly, the children of first generation are more likely to because they grow up in the new culture, they're more likely to adapt and learn, and they'll be speaking with the right accent, and so they will have different ideas than the first generation. And first generation, some individuals are very good at moving across, being, you give up at acculturating that, you may change your language, you may change your diet, you may change your clothes, but there are other values which are very difficult to give up.
That's right.
So,
Marianne, sorry, Marianne, would you like to add something?
Yes, I will, because I live in a country where things are changing so rapidly you cannot imagine. We are now, right now, the last week, we have, when persons want to become citizens in my country, they have to pass all kinds of tests. And then it has to go to parliament, who gives them citizenship. Well and good. Now, some political parties have decided, oh, if you ever on social media or to somebody else has expressed an idea like, I don't think homosexual is a good thing, or I don't know what, then you are taken in for personal interviews with members of the parliament, who is going to see whether your values are sufficient in order to become a citizen in our country. This has become, I cannot tell you, we have moved away from accepting different cultures. We have social democrats who are now saying that even though you have a good education, you have a good job, you have everything fine, how can we ensure that in your mind you do not have some non-Danish values hidden somewhere? So we have better check it.
So then it's turn to advocate for them, as Dinesh underlined it before. So we have now to call for colleagues for advocate for all these people. Dinesh, what would you like to add here?
About advocacy?
Yes, advocacy, it would be really very important if the politics go restricting legislation more and more.
I think there's several things about advocacy that we need to remember. First and foremost, it's not once, it's a repeated effort, not only by one person, but by a group of people, by community, by social groups, by religious leaders, etc. Optimistic thing is that you never know when a door will open and they will allow you to go in and convince them. It's about having research evidence. It's about having personal stories. Every time I'd gone to see politicians by myself, they would say, yeah, you're a psychiatrist. You would say that, wouldn't you? But every time I went with a patient, their attitude changed dramatically because they understood the patient as a human being. And the other challenge to politicians is, what do you want to be remembered for? What do you want your legacy to be? They are interested in only 18 months till the next election.
Okay, but the time is running. Maybe you can give one recommendation or one, not advice, but maybe suggestion. What can we do to improve the mental health services? You mentioned a lot, you both mentioned a lot of points, but what are the most important solutions?
I think being open-minded, being aware of your own prejudices, being aware of your strengths and weaknesses and that of your culture, and treating the other person not as a nuisance, but somebody who's in desperate need.
Okay, thank you, Marianne.
Yes, I think another aspect is to have a diverse a group of professionals dealing with mental health issues, that you invite people from other cultures with other backgrounds and points of view to become an integrated part of the workforce, so that you are able to meet also as a person from the native country, others who are migrants, and to see that they are doing an excellent work and that they are providing fine services, even though they have another background. And you may say, oh, how can they integrate? Yes, they have integrated. So I think we should be very open-minded as health professionals to allow others to join us.
There are also some questions in the chat. Maybe we get back to them. Thanks a lot for the inspiring talk. My question is regarding the offer of mental health psychosocial support to migrants. Is it better to have them access mainstream psychotherapy service versus specialized one reserved to migrants, refugees? It's the question, do we need...
I think it needs to be tailored according to their need. They may need something short-term to get over the trauma, and then they may need something more long-term, depending upon the circumstances and the losses and so on and so forth. But the principle really is that whatever you do, make sure that individual sitting in front of you is getting the best you can give them, and make sure that they have other support systems, because you can't be with them 24 hours a day.
Okay, thank you. Marianne, another question, maybe a short answer regarding the language competencies of patients. There is a question, also the language plays an important role for the migrants to adapt in the society, but also when working with a psychologist or psychiatrist. How influenced do you think language barriers are, and does the EU has any program or policy to ensure that public health counts with multilingual services? Maybe a short answer?
That's difficult to answer short, because I think it depends from country to country to what extent that they provide interpreters. In some places, it is provided by the public system. In others, you have to pay yourself. So I think it is not easy to say, but I do believe that you should have available interpreter services in countries with languages that are not familiar to others. And that it should be professional persons, not family members, children, what is very often used. But I don't know if, frankly, if EU has some directives about interpretation. I'm not aware of it. I'm sorry.
I do not know it. Dinesh, do you know any programs or any recommendations done by the EU?
I'm not aware of them.
Okay. So it's important to have language competencies to understand your patient owner and to be understood, because we know that this is a risk factor to be involuntarily, if you are in an emergency center or room, to be involuntarily treated or medicated and so on, because
I think that goes back to the openness of mind, because we can't be competent in all 193 plus languages plus thousands of dialects.
That's right. So we have to stop here. I'm sorry, Dinesh, because time is over. Thank you very much. I took a lot of information. The issue which we didn't discuss is reframing with terms, for example, refugees or improving resilience, coping strategies, and so on, or other solutions would be great, but the time is now over. I would like to thank all of you, to the presenting speakers, Marianne Kastrup, Professor Dinesh Bhugra, the leading expert in this field, to all of you for your patience, for your comments and questions, and of course to our colleagues in the headquarters who made it possible that we are now here in this space. Thank you very much to all of you, and have a good day.